Welcome. This briefing is a high-density distillation of the 2026 Consensus Guideline on alpha-synuclein diagnostics for Parkinson's disease. We're going to focus exclusively on the core practice-changing updates that you can apply immediately in your clinical workflow. So, the big picture here is a fundamental shift in how we think about synucleinopathies. We're moving definitively away from a diagnosis based purely on clinical science, a syndromic diagnosis, to one that is anchored in objective biological proof. Here's our agenda. We'll cover the new biological definition, the primary and emerging assays, touch on differential diagnosis and genotypes, review how to handle negative results, and then wrap up with the key practice changes. We'll move through this quickly and efficiently. All right, let's begin with Section 1, the new biological framework that underpins everything else in this guideline. The central principle that makes these new assays possible is the direct detection of alpha-synuclein seeding activity. This is essentially a prion-like pathogenic mechanism. Pathological aggregates act as a template, forcing the misfolding of native monomers. It's this exact process of amplification that we now leverage for diagnosis. Moving on to Section 2, the primary diagnostic assays. Now, these are the core recommendations that are going to directly impact your day-to-day clinical workflow. Okay, this is the headline recommendation. It's a Strength I Evidence 1B designation, which means it's a strong recommendation that's backed by high-quality evidence. It now officially establishes both cerebrospinal fluid and skin-based alpha-synuclein seed amplification assays, or SAAs, as the go-to first-line auxiliary tests when you have a high clinical suspicion of a synucleinopathy. Now look at the data. What's striking here is the high and directly comparable diagnostic performance. Pooled data show sensitivities and specificities well over 90% for both the CSF and the skin SAA. The validation of a less invasive skin biopsy is a game changer. It gives us a powerful alternative for patients where a lumbar puncture is either contraindicated or simply declined. And as you can see, immunohistochemistry for phosphorylated alpha-synuclein remains a very strong secondary option. To ensure the accuracy and reproducibility of the skin SAT, standardized sample handling is not just recommended, it's mandatory. The preferred biopsy site is the posterior neck. You have to ensure the depth is sufficient to capture that dermis subcutaneous junction. The sample then needs to be flash frozen immediately at -80°C and, of course, protected from any freeze-thaw cycles which would destroy the seed integrity. Okay, Section 3, Emerging and Screening Assays. Let's assess the less invasive tests, paying close attention to their specific roles, and importantly, their current limitations for proper clinical use. This table really lays out the current landscape quite well. Blood-based SEA shows the most promise right now, with optimized methods hitting around 80% sensitivity and over 92% specificity. The catch? It requires complex preprocessing, like immunoprecipitation, to get rid of inhibitors. Other modalities like oral and olfactory mucosa sampling are highly specific, yes, but their sensitivities are currently just too low for frontline diagnosis. This positions them strictly as potential screening tools, not diagnostic ones. All right, Section 4. This is about differential diagnosis. We're going to cover how these assays provide critical nuances for telling apart the different synucleinopathies and for managing specific genotypes. This really is a major advance for the field. The distribution pattern of phosphorylated alpha-synuclein in skin biopsies is an incredibly powerful tool for differentiating Parkinson's from MSA. In PD, you see this proximal to distal gradient, with deposition concentrated in autonomic nerve fibers. In MSA, on the other hand, the deposition is uniform, and it's found mainly within somatic sensory nerves. This is a key histological differentiator you need to know. And we see a similar story with the SAA kinetics, which provides a molecular basis for this distinction. This is based on the alpha-synuclein strain hypothesis. What we see is that MSA-derived seeds trigger faster aggregation, but they produce a lower final fluorescence plateau from the thioflavin T reporter. This is in contrast to PD-derived seeds. These distinct kinetic profiles are a direct reflection of underlying conformational differences in the pathological aggregates themselves. Now, this is imperative to remember. For your patients with LRK2 mutations who often lack that typical Lewy body pathology, SAA demonstrates superior diagnostic sensitivity. In cases where your standard p-alpha-synuclein IHC comes back negative, a brain tissue or CSF SAA can still be positive and establish the diagnosis. This really makes SAA an essential tool in these genetically defined and diagnostically tricky cases. Okay, Section 5. How do we manage negative results? Having a standardized protocol for a negative test, especially when you have a high degree of clinical suspicion, is an essential part of implementing these assays in your practice. So, what do? Well, the guideline addresses this critical question directly, and it gives us a standardized protocol to follow. So here's the algorithm. First, you ensure technical validity, run 2 to 3 replicate tests, and also run a dilution series to rule out any kind of assay inhibition. Second, conduct a thorough clinical reevaluation. Integrate all the genetic and imaging data you have. Finally, establish a clear plan for follow-up testing in about 6 to 12 months or sooner if there's clinical progression. This protocol is designed to minimize false negatives and to standardize ongoing patient management. And that brings us to our final section, a concise summary of the key practice changes for you to integrate into your clinic starting now. So let's crystallize the core actionable changes. 1. Prioritize SAA from CSF or skin as your first-line tests. 2. Use skin IHC as a robust, highly specific alternative. 3. Leverage both deposition patterns and SAA kinetics for that crucial PD versus MSA differential. 4. For your LRK2 mutant cases, always remember SAA's superior sensitivity. 5. Systematically apply the negative result protocol every time. And 6. Use blood SAA judiciously as an emerging screening tool, but always interpret it within the full clinical context. So we'll conclude with a forward-looking thought. Right now, these assays give us a binary, a yes or no result. The next frontier isn't just about detection. It's about developing quantitative assays to accurately measure the total seed activity. This is going to be absolutely essential for objectively monitoring disease progression and, maybe most critically, for measuring therapeutic response in all the disease-modifying clinical trials that are on the horizon.